Good afternoon. I'm Debbie Patterson. I'm a dermatology PA. I've been practicing in dermatology for over 20 years. And I'm excited today to talk to you about the use of gene expression profiling to inform management decisions for your skin cancer patients. We will talk about the clinical validity and evidence for our new DecisionDX Squamous cell carcinoma test, as well as our new integrated 31 GEP test result, and the clinical validity and evidence for DecisionDX Melanoma. Castle Biosciences has a number of current prognostic and diagnostic solutions for patients. We started in the uveal melanoma space, and our assay is now the standard of care. We've recently added the squamous cell carcinoma DecisionDX test, and we've had the DecisionDX Melanoma test for quite some time. We're also happy to now offer a comprehensive diagnostic set of tests, including MyPath Melanoma and DecisionDX DX Melanoma. That's for those hard to categorize, difficult to diagnose melanocytic lesions that we've all seen many times. We're going to start with talking about the DecisionDX squamous cell carcinoma. Squamous cell sort of takes the backseat to melanoma for very good reasons, but it can be easy to lose sight of the fact that quite a few patients die every year from squamous cell carcinoma. Because this is not a reportable illness, we have limited data compared to the melanoma space. I always like to start by thinking about real patients because that's what we're all here to really talk about. So these two patients are extremely similar clinically. The patient on the left is a 69-year-old white male, status post-liver transplant with a 1.5 centimeter poorly differentiated squame on his left temple. Based on current staging, AJCC 8, he's a T1, and Brigham Women's, he's a stage 2A. The patient on the right is a 64-year-old male, status post-liver and kidney transplant with a 1.3 centimeter poorly differentiated squame on the temple. Same staging, obviously. So if I had these two patients in clinic, I would think that they would have a similar course, and I would frankly treat them both exactly the same. So as we go through the data, I'd like you to sort of transpose it onto this scenario in your clinic of when you're looking at this patient, how do you specifically manage him? I mentioned the increasing incidence of squamous cell carcinoma. Approximately 15,000 patients die from squamous cell carcinoma every year compared to 7,000 melanoma patients. And that is due to the significantly greater incidence of squamous cell compared to melanoma. There's a lot of difference in the way clinicians manage squamous cell carcinoma. We do have two currently utilized staging methods. One is AJCC 8, but this applies only to lesions of the head and neck. The Brigham Women's criteria relates to the number of high-risk features and ranges from a T1 to a T3. The high-risk features that are include tumor diameter greater than 2 centimeters, poorly differentiated histology, perineural invasion, and invasion beyond the subcutaneous fat. When we looked at the literature and tried to determine how accurate these current staging methods are, it was surprising to learn that a significant number of patients are understaged, which means that our low-risk T1, T2A patients actually had a metastatic event, and that ranges from 16 to 60% of our patients with a median of 31.3. On the other end, even more patients were found to be overstaged. So those were T2B, T3 patients that we were following very aggressively, expecting metastatic events when in fact they did not happen. This was very common with an incidence ranging from 61 to 94%. So certainly looking at this, we realize that we need to be more precise in our staging and therefore management of our squamous cell patients. So we developed the DecisionDX SCC test. This is a 40 gene expression applied to a validated neural network algorithm that classifies your patients as class 1, low biological risk, class 2A, moderate, and class 2B, high biological risk for metastasis. This assay is not indicated for the general squamous cell population. It is indicated for use in patients who have at least one or more high-risk features. Those are listed for you on the slides. Of course, it's most common that we would diagnose them at the time of the examination in the derm office. These features include a large tumor greater than 2 centimeters anywhere on the body, location on those H or M areas, immunosuppression, rapidly growing tumor or one with poorly defined borders, any tumor at the site of prior radiation or chronic inflammation, and any neurologic symptom at the site of the tumor. Those high-risk patients most commonly are referred to MOs for treatment. And when the patients are surgically treated, at that point, additional high-risk features can be identified. Those include perineural involvement, poorly differentiated histology, invasion beyond the subcutaneous fat, aggressive histologic subtypes, including vasosquamous and many others, and lymphovascular invasion. We do mention a Breslow greater than 2 or Clark level greater than 4. Honestly, having looked at hundreds of squamous cell pathology reports, I've never seen those parameters documented, but if your pathologist is different, you can still consider those to be high-risk features. So these are patients for whom the test has value. We looked back at our first 1,000 patients tested, and it was noted that most patients had at least 2 or more risk factors. The risk factors are listed on the right in order of descending incidence. So the most common risk factor was location on the H or M area, and the least common risk factor was prior radiation or chronic inflammation. So that's often those patients with pretibial lesions who have stasis dermatitis or patients who have had prior radiation. What is the evidence? Science is great, but we need to be convinced that this really works for our patients. When we look at this Kaplan-Meier curve, we know it's a strong curve because there is distinct separation between the groups, and the p-value is 0.001. So we have strong data, and when we take these numbers and look at the overall cohort of the patients, 212 had a class 1 result, and those patients had a 6.6% metastatic event rate. 185 were class 2A with a 20% metastatic rate, and 23 of the patients were class 2B, and those patients had a 52% metastatic rate. So there is a definite stratification of patients between class 1 and class 2. The variables were assessed using multivariate analysis, and it was found that a class 2B gene expression profile result is the strongest predictor of metastasis. And that is when it's compared to immunosuppression, tumor diameter, perineural invasion, deep invasion, and poor differentiation. I know, having worked with many physicians over the years, most of my physicians really relied on poor differentiation and deep invasion to be the greatest predictors of high risk for squamous cell. While looking at this, we see that a 2A result has a hazard ratio of 2.3. It's independent, and it's similar to deep invasion and poor differentiation. So 2A patients do have increased risk. Looking at the 2B result, the hazard ratio is 6.9, and it's 3 times stronger than any of our other high-risk features for predicting metastatic risk in squamous cell patients. So the 2B result is very impactful. So we're back to our 2 patients. Surprisingly, although their clinical pathologic features are nearly identical, the patient on the left had distant metastasis and eventual death from his squamous cell, whereas our patient on the right had no evidence of recurrence. This really highlights the reality that our current staging is not directing us in the best way. And we need something different that can give us specific information so that we can appropriately manage our patients and decrease those 15,000 deaths every year. Our patient who had distant mets and death had a Castle 2B result. Our patient who did great without evidence of recurrence had a Castle class 1 result. So this is the information that we've been looking for to guide us in managing our patients. Data is great, But the real truth is that you're going into your clinic on Monday morning to look at your path log, and you need to say, what does this really mean for my patient management? A group of esteemed Mohs surgeons, surgical oncologists, and one radiation oncologist from academic and community practices developed a working group to give us guidelines on how to integrate the test result into patient management. The experts looked at the clinical pathologic staging and treatment guidelines currently in existence, as well as the published expert recommendations and studies. They used that information to focus on decision-making points where information from the gene expression profile may inform the clinical management in these specific areas: baseline nodal evaluation, adjuvant radiation therapy, follow-up, and surveillance. When we're thinking about nodal evaluation, we see that patients who have a class 2A or 2B result should be considered for baseline radiologic imaging of the draining nodal basin. Patients who have Brigham Women's AJCC high-risk staging with a class 2B result are the patients who are good candidates to consider a sentinel lymph node biopsy. When we look at the decision regarding whether or not to refer patients for adjuvant radiation therapy, we can again use the GEP in conjunction with current staging. And for the patients who have a high-risk stage with a class 2A or 2B CASA result, we can consider referral to radiation oncology for multidisciplinary discussion. But in the patients who are high-risk staging with a class 1 CASA result, we can reconsider that those patients may not be the best candidates for adjuvant radiation because their recurrence rates are low and the morbidities may outweigh the benefit. The last decision that we must decide is, how do we follow these patients? So clinical follow-up of a class 1 patient may involve nothing more than clinical skin exam and nodal evaluation. Patients who are in the moderate and high-risk categories of 2A and 2B should have those same clinical follow-up in addition to nodal ultrasound and CT scanning once a year. The working group advised that patients with class 2B results should be considered for clinical follow-up as well as baseline and twice annual nodal imaging. They put this into sort of a concrete algorithm in conjunction with NCC and guidelines, and that's a point that I would like to make. CASL is never suggesting that their gene expression profile results either circumvent or supersede current staging. We are suggesting that this is additional information that allows you to make patient-specific decisions for management. So when you look at those low-intensity patients, those class 1 patients, of course, every squamous cell carcinoma should be surgically excised when feasible, and every patient should have routine skin and nodal exams. For those low-risk patients, this may be all they need, 1 to 2 times a year in the derm office with a skin and nodal exam. When the patient increases to that 2A result, which is moderate intensity, they need more frequent clinical follow-up, 2 to 4 times a year. We should consider oncology referral, as well as baseline and annual nodal imaging for the first 2 years. Squamous cell carcinomas tend to metastasize and recur much faster than melanoma, and that's why the aggressive management lasts for 2 years. For the high-risk 2B patients, we should also consider radiation oncology, medical oncology, and nodal imaging. These patients need to be seen much more often, up to 4 times per year for the first 3 years, and twice annual imaging. So that's squamous cell. It's a lot of talking, but I think the summary that I'd like for you to take home is that our current staging is not precise. It is frequently overstaging and understaging patients, and it is imperative that we increase surveillance of our high-risk patients. And the way that we can identify those patients is through gene expression profiling, where we look at each patient's specific tumor biology. We can coordinate this in line with current guidelines to give our patients the best management possible. I love anything that's concrete and precise, and I love the algorithm that we've been given by the experts in the recent publication in the JDD. So feel free to take a look at that article and feel free to ask any questions that come up after you do. So now we will talk about DecisionDX Melanoma. This is what scares many of us as providers. I know it certainly always caused me to think very hard about each individual patient. This is what I call a good news, bad news slide. The good news is that we as derm providers are doing a really great job. We are identifying melanoma patients at a very early stage. 80% of cutaneous melanoma patients are diagnosed at stage 1, 12% at stage 2. So 92% of our patients are being diagnosed at those low risk early stages. And that makes us happy. And we think now our patients are going to do better and our melanoma statistics should be improving greatly, and they're not. The reason is that the majority of melanoma deaths, 60%, occur in those very same patients who were early stage, low risk at the time of diagnosis. For me, this is a terrifying fact because I follow guidelines. And when my patients are stage 1 and stage 2, I don't send them for imaging. I often don't even recommend a sentinel lymph node biopsy. Now I look back and realize that there's no doubt that I have contributed to bad outcomes for my patients. We must improve prognostic accuracy so that we can define which patients are truly high risk so that we can stratify those patients into intense imaging so that we can identify recurrence at the earliest phase. We now have great treatments for our melanoma patients. We're not relying on interferon as we did for many years. Recent studies have shown that if we identify recurrence when it's asymptomatic, our patients are twice as likely to survive. It is our duty to find out which patients should be imaged, followed more aggressively, so that we can identify the recurrences early. Another recent publication showed that patients who are undergoing imaging, 80% of the time, their recurrence will be detected at the asymptomatic level. This is a very busy slide, but what it's intended to show you, again, is that AJCC has significant gaps. When you look at the data, we're looking at 5 and 10-year melanoma-specific survival. We see that the patients on the right who were stage 3A and 3B actually had lower survival than our 2B and 2C patients on the left. Again, this is concerning data. This shows us very objectively that our current staging is not all that we need to manage our patients. So the DecisionDX Melanoma helps us to inform 2 important clinical decisions. One is, does our patient need to be referred for sentinel lymph node biopsy? And number 2 is, what is our patient's risk of recurrence? Thereby, how do we follow them? Do they need imaging? Do they need referrals? We can categorize our patients as low or high risk, and the NCCN recent guidelines have identified that it should be a patient's individual risk of recurrence, individual risk of sentinel lymph node biopsy that should guide their management decisions. The DecisionDX Melanoma test is indicated for invasive melanomas, any stage 1 to 3 patient. It's a 31 gene expression profile applied to a validated algorithm to give us 4 different results. Class 1A is the lowest risk. Most patients will have a Class 1A result. The next most common result is the Class 2B. These are the highest risk of recurrence and metastasis in the first 5 years. About 15% of your patients will fall into that intermediate risk of 1B or 2A. We call these increased risk. So again, it's the question of what do we do with this information? We're looking at path log, we're deciding what to do, and we have to decide, do we send this patient for a sentinel lymph node biopsy? Well, currently, the patient selection is based on the T stage, and that is considering the Breslow thickness and ulceration status. Current guidelines dictate that a T1A patient has less than 5% risk of a sentinel lymph node biopsy and therefore is not eligible for the procedure. Patients T1A with high-risk features through T1B are in an intermediate risk of 5 to 10%, we should discuss and consider a sentinel lymph node biopsy for these patients. Any patient T2A or above has a greater than 10% risk of sentinel lymph node biopsy and should be referred and consider the procedure. These recommendations came from the landmark MSLT1 trial. This 5% threshold is based on the 5% false negative rate for nodal recurrence seen in the study. Unfortunately, with this guidance, the overall rate of sentinel lymph node positivity is surprisingly low at approximately 12%. I realize you can do the math, but that means that 88% of patients who undergo this procedure will have a negative result. Again, very surprising data for me as a provider. So we need to improve selection. And why is that? Well, because again, the majority of patients who undergo the procedure are negative and therefore derive little to no benefit. Furthermore, the MSLT1 demonstrated there is no survival benefit and a very low sensitivity for the sentinel lymph node biopsy. Specifically, 2/3 of melanoma deaths are sentinel lymph node negative patients. So we have this gold standard that we're using to guide our management, and we find out that in 2/3 of patients, it leads us down the wrong road. The false negative rate for sentinel lymph node biopsy recurrence is 5 to 21%. We're not saying this procedure has no value. We are saying we want to refer the patients who will benefit from this procedure, who will have a good reason to undergo anesthesia and take the risk of complications. And on the other side of the coin, we can safely avoid those risks for patients who are genuinely low risk. Taking this a step further, Castle has now developed an integrated 31 gene expression profile result. I think this is profoundly helpful in patient management. They started with a cohort of 1,398 cutaneous melanoma patients to develop a training cohort. The cohort was representative of the general cutaneous melanoma population. Multiple variables were evaluated for inclusion. I won't bore you with all of those details, but they are what you would expect them to be. The integrated 31 GEP was developed, and from the training cohort, we learned that the strongest algorithm for sentinel lymph node prediction includes the following: a 31 GEP continuous score in conjunction with Breslow thickness, ulceration, mitotic rate, and age. The other parameters that we'll look at next were not impactful for the algorithm. And of these 5 variables, the 31 GEP was the strongest predictor of sentinel lymph node positivity. So the algorithm is trained, developed, and now, of course, we must validate it. So there was an independent validation cohort of almost 1,700 patients, again, representative of the standard cutaneous melanoma patient, and the results showed that the I31GEP offers a precise and personalized likelihood of sentinel lymph node positivity for patient management decisions. So you will now see this as part of your result. And just, again, to review, this was a very thorough and extensive review of clinical pathologic features that we have used. And when we looked at it, we've talked about the ones that were statistically significant and impactful, but we would like for you to see the ones that did not contribute to the accuracy of the algorithm. And regression was one of those that tends to surprise a lot of providers. The test was validated using linear regression, and it showed a slope of 0.999, which means that it is 99.9% accurate in predicting sentinel lymph node positivity rates. I've rarely seen anything in medicine that is that accurate. So what does the result on your desk look like? Right in the center, you will see your integrated result that gives you a very specific, personalized risk of sentinel lymph node positivity for your current patient. All of the information is included, including the clinical pathologic features. On the right, you will see the recommendations that are in place based on clinical histopathologic features. So whenever you look at the report, you can sort of think of that MSLT1 study where we said less than 5%, not eligible. 5 to 10%, discuss and consider. Greater than 10, offer and refer. I always take this back to the real patient. This is actually not a real patient, it's a vignette, but it's very helpful in showing you how to really use this data. We first look at a 56-year-old male who has a T1B melanoma with a Breslow of 0.5, no ulceration or mitoses or other high-risk features. Based on our current information, this patient falls into the 5 to 10% likelihood of a sentinel lymph node biopsy. So for this patient, based on current staging, we would discuss and consider. When we assign this exact patient a 2B result with a continuous score of 0.76, his individualized likelihood of sentinel lymph node positivity increases from that 5 to 10% to 13.4%. Based on the data, this is a patient who should be referred for a sentinel lymph node biopsy. At the same time, when you look at this exact patient with the same clinical pathologic features, if he has a class 1A result with a continuous score of 0.12, he drops to a likelihood of sentinel lymph node positivity of 3.93. This is now a patient who's in the range to safely forego the sentinel lymph node biopsy procedure. These are those patients, the 88%, who are going to have a negative sentinel lymph node. Another patient is a T1A as well. He's 66 years old. His Breslow is 0.7, and he too has no other ulceration or high-risk features. What do the current guidelines say for him? They say that this patient has less than 5% risk of sentinel lymph node positivity, and this is the patient who should not be referred for a sentinel lymph node biopsy. When we look at an integrated test result, this patient can range from 3.1%, again, can safely forego. With a different tumor biology, this very same patient now has a 15.1% personalized likelihood of sentinel lymph node positivity. So I hope you can see the very precise nature of this information and the way that we can use it to properly manage our patients. I really have appreciated this result when I discuss the pathology with my patient. I show them this page and I show them why I am or am not referring them for sentinel lymph node biopsy. Patients are very informed, and it is very common for me to make recommendations to patients and then have them come back 1 or 2 days later, having Googled, having talked to their family and saying, you know, why am I not getting a sentinel lymph node biopsy? My neighbor had melanoma and she got one. On the reverse, I have patients saying, wow, my best friend had a sentinel lymph node biopsy and she missed work for 2 months, and I don't care what you say, I'm not going to have it. Well, I can now show her, well, the reason I really think it's worth the risk for you is that you have a 15% risk of having a positive node. And based on the literature, that's significant. Okay, so that's a lot about sentinel lymph node biopsy, but we also have to think about risk of recurrence to determine how we manage our patient. When we look at AJCC 8 staging, 1, 2, and 3, and specifically look at 5-year melanoma specific survival, we see that stage 1 patients have a 98% 5-year melanoma specific survival. Stage 2 patients have a 90% 5-year melanoma specific survival, and the stage 3 patients have only a 77% 5-year melanoma specific survival. When we have these patients undergo gene expression profile testing, we can see that the patients who have that high risk Castle 2B result have a very different course. The stage 1 patients who have a high risk 2B result drop to a 91% 5-year melanoma specific survival, and their tumors behave more like a 3A lesion. The stage 2 patients drop from 90% to 85% 5-year melanoma specific survival. They behave more like a 3B patient. And the stage 3 patients who have a Castle 2B result have a 5-year melanoma specific survival that drops from 77 to 62%. And these patients behave more like a 3C plus patient. That certainly alerts us to the fact that these patients with 2B results need more intensive surveillance. On the happier side, when those same patients have a low risk Castle 1A result, they have a much higher 5-year melanoma specific survival. The class 1 patients increase to 99%. They don't have very far to go. And the stage 2 patients who have a class 1A result increase their 5-year melanoma specific survival from 90 to 98%. And those stage 3 patients increase their 5-year melanoma specific survival from 77 to 94% if they have a Castle class 1A result. They then behave more in line with the 2A staging. So this is a nice visual representation of the difference in your actual patient outcomes based on their gene expression profile testing. This is just that same data and how it's reported with your complete report from Castle. And you can see that we're looking at on the left, AJCC staging, and then how it matches up when you apply the Castle test result to those variously staged patients. Again, this is precise, specific information that you can review and that you can show your patients. Lots of Kaplan-Meier curves are not really for specific dissection, but they are here to show you that our data is extremely consistent and strong, whether it's an archival study, a prospective study, multiple peer-reviewed publications show the strength of this data. A recent publication by Arnaud involved a cohort of 383 patients from their melanoma program, and this included patients, all of whom underwent a sentinel node biopsy and a 31 gene expression profile test. This was an unselected population. It is a prospective cohort, and it is independent. There was no industry sponsorship of this study. Of those 383 patients, 251 had a class 1A result, and 132 had a 2B result. 42 patients of the 383 had recurrences. 3% of those were 1A, and 24% were 2B. When we look at this graph, we see that patients who had a 1A result with a positive lymph node had fewer metastatic events than patients who had a 2B result and a negative node. Again, this reinforces the fact that having a negative sentinel lymph node biopsy does not mean that your patient is not high risk and does not mean that he or she does not need intense surveillance. So Dr. Arnaud proposed 4 utilities for the 31 GEP based on his study. He proposed that the test can be used to identify patients who are GEP class 1A, node negative, who are truly at very low risk for relapse, approximately 2%. These are patients who can be reassured. They can be followed up exclusively by dermatology. They don't need intense surveillance. We can leave those resources for the other patients who will benefit. He also suggested that the 31 GEP can be used to identify patients who are sentinel lymph node negative, but still have a higher risk for relapse because of their specific tumor biology, class 2, even though their stage is low. As well, the 31 GEP test combined with patient age and tumor thickness can help identify patients who can elect to forego the sentinel lymph node biopsy based on their personal preferences and their comorbidities. And lastly, the small retrospective series suggests that the GEP class separates a subset of patients with 3A melanomas that can guide medical oncologists to advise patients of their need for adjuvant therapy. These are our most recent publications related to the validity and utility of the 31 gene expression profile. The first publication by Shea et al. Involved 323 patients. It's a prospective registry, multi-center. The results showed that recurrence rates in patients with a 1A result were 5%. Patients who had a 2B result had a 40% recurrence rate. Metastasis in 1A patients was 2% compared to 23% in the 2B patients. The prospective multi-center study by Podlipnik et al. Involved 86 patients and had similar results, 1A patients had a 5% risk of recurrence and 2B patients had a 33% risk. 1A patients had a 0 risk of metastasis, and the 2B patients had 14% risk. Lastly, a retrospective single-center publication by Dillon and Dillon involving 202 patients showed recurrence rates of 4% in class 1 patients and 27% in class 2 patients. Metastasis was 1% in the class 1 and 17% in the class 2. When you look at all three of these studies, you see the recurrence rate for Castle 1A patients ranges from 4 to 5%. Metastatic rate ranges from 1 to 2% in the 1A patients. In the 2B patients, the recurrence rate ranges between 27 and 40%, and the metastatic rate is 17 to 23%. The last study published by Marston et al. Is a clinical impact study. 589 of our peers who attended a recent dermatology conference were surveyed. 73% of the respondents suggested that the 31 GEP would benefit their patients' understanding and knowledge of their disease. 66% of our peers reported that the 31 GEP could be beneficial to identify true negatives in otherwise high-risk populations. And 71% of our peers said the test could be beneficial in identifying true positives in low-risk populations. I always like to look at a real case because whenever I look at data, I'm always thinking of this patient or that patient because these patients become very close to us. I always call them sort of my extended family because anyone who has a cutaneous malignancy is somebody that we follow much more frequently. So we sort of become part of their lives and we want to do the best thing we can for them. So the first actual case study here is a 34-year-old female who was diagnosed with a malignant melanoma on her right arm. Her Breslow was 0.6. She had no ulceration. Her mitoses were less than 1. The base was not transected and she had no high-risk features. Based on current NCCN guidelines, this patient is not eligible for a sentinel lymph node biopsy. She is a AJCC 1A T1A patient. I think most of us agree we would ask her to return for a wide local excision. At this point, I tell my patients, this is a surgical cure. We need to see you every 6 months for at least 5 years and then annually. This patient would never be referred for routine blood work or imaging. Because this patient was 34 years old, her provider decided that he wanted to order a gene expression profile. Her result was a 2B. Now her 5-year recurrence-free, distant mets-free, and melanoma-specific free survivals dropped to 51, 65, and 89% respectively. This changes everything. Her treatment plan was subsequently updated and she was referred to medical oncologist for high-intensity surveillance. Her initial CT scan was negative. When she returned in 6 months, she was found to have a biopsy-proven oligomet to her lung that was BRAF negative. She was immediately started on combination ipilimumab, nivolumab therapy, and as we suggested earlier, because her recurrence was detected when it was asymptomatic, we have now doubled her chances of responding to therapy and surviving her melanoma. And that's the case for this patient. After 48 months, her scans are clear and she is doing great. This case is particularly important to me because I'm 52 years old and I think that I have a very long life ahead of me. And I certainly know that I would want to undergo the most appropriate and specific treatment if I had a melanoma at this point. This particular patient had a Breslow of 1.2 with no ulceration. The base was not transected. There were no mitoses, regression, and the Clark level was 2. Based on current guidelines, this patient was eligible for a sentinel lymph node biopsy. His AJCC stage was 1B T2A. So based on guidelines, he underwent a wide local excision as well as a sentinel lymph node biopsy. He was not referred for blood tests or routine imaging, and he was seeing dermatology every 6 months. When he underwent that biopsy, he joined the group of 88% of patients who had a negative result. Again, historically, we would take that result and reassure our patient that his risk of metastasis is very low. Again, he underwent a gene expression profile test, and he too had a 2B result. Based on this patient's Castle 2B result, his treatment plan was updated. He was referred to medical oncology for high-intensity surveillance, and his baseline PET CT scan revealed that he had contralateral metastasis. He was upgraded to stage 4, and he was offered immunotherapy for low burden of disease. To me, this data and these cases are both terrifying and encouraging. The terrifying part is to think back over the number of patients that I have monitored and treated based on current guidelines, and the realization that there is no doubt that some of my patients had bad outcomes, even though we followed guidelines. That makes me very sad. The good news, though, is that I know moving forward, I can provide patient-specific tumor biology, precise management of my melanoma patients. Because I felt so strongly about the utility of the test, I had my office manager pull all of my melanoma diagnoses over the last 3 years. And that is the cutoff. You can send a specimen that has been obtained anytime over the prior 3 years. The benefits are that no patient needs any further procedure. The primary biopsy specimen is used. The Castle lab will contact your dermatopathology lab and take care of acquiring the specimen if you send in the requisition. I personally called every single one of my appropriate patients, advised them of the technology, and asked if they wanted to have the test. Every single patient wanted the test. Most of them said, why would I not want to have this additional information? Whenever I looked at those results, a small number of patients were found to have the 2B result, and that's consistent with the data. Those patients were upgraded and sent to medical oncology for intense surveillance. One of those patients was found to have metastasis and was started on combination therapy. Many more patients had a 1A result. And you may say, well, that's not very helpful because they're low risk. It's very helpful to the patient. When you tell a patient you have cancer, you have a melanoma, most people know somebody who has died from melanoma. It's a terrifying disease. And despite what we say, we have never been able to very precisely reassure our patients that their risk is definitively low for recurrence. I've had many patients who stopped having their family vacations at the beach, did not want to go out, could not do anything but ruminate about their melanoma. When I gave those patients their 1A result, it truly changed their lives. I had spouses thanking me, patients thanking me, employers thanking me, because now their patients were living again. Another really wonderful case I had was a 30-year-old female who had a history of melanoma, who now is married and wants to have a pregnancy. But she was too afraid to have a pregnancy because she was afraid she would have a recurrence of melanoma and not be around to be a good mom to her baby. She had a Castle 1A result. She went on to have a healthy pregnancy, and having followed her since the time of her result, she is happy and absolutely credits Castle for allowing her to move forward with a pregnancy and have a fulfilled life. So, you know, I don't want to get too much into the tearjerk zone here, but it really is the reality of how this affects patients. Why is this test right for your patients? More than 5,700 patients have been studied, including independent validation studies. We have 30 peer-reviewed published studies, including 2 meta-analyses to validate the test. Over 65,000 patients have been tested. With more than 7,200 of your peers ordering the test, the data achieves level 1A evidence, and 1 in 2 patients have had their management changed because of their CASA result. Because of all of this robust data, Medicare covers the test, and we have some level of coverage from 200 other private insurers. If your patient does not have coverage, CASO has an industry-leading patient assistance program. This is not at the level of the 20 manufacturer coupons you have in your office. This actually is a guarantee that your patient will not receive a bill. Please know that your patient will receive an EOB. Let them know that so that when this comes in the mail, they're not terrified. But I can tell you that over 2 years of ordering the test, I never had a patient get a bill. So you can feel very confident when you order. Quickly, I'd like to end with a new comprehensive diagnostic offering that is part of the Castle testing. All of the tests that we've discussed today have been prognostic tests. These are diagnostic assays, and these relate to difficult to diagnose melanocytic lesions. There are over 2 million pigmented lesion biopsies done every year. Over 130,000 of those are invasive melanomas. About 96,000 are melanomas in situ. Up to 300,000 of the 2 million cannot be confidently diagnosed with routine H&E. I know that you've seen these reports. I hate these reports. They say this lesion's benign, but patient needs an excision. On the flip side, my very favorite was cannot rule out possible early evolving melanoma. What do I do with that? First of all, when I try to explain that to a patient, I really look incompetent. It looks like, why did we have a biopsy and you still don't know what I have? And I understand that. And then we have to decide, what are we going to do with the patient? Is this benign, or does the patient need a wide local excision? So this is very important. And of the biopsies that are done, the majority are definitively benign, 74%. 11% are definitively malignant. Those are the easy ones. It's the 15% in the middle that have uncertain malignant potential. And those are the patients that we're trying to help. Whenever the dermatopathologist has a specimen of uncertain biological potential, that's when they add IHC stains and levels and consider presenting at conferences or getting second opinions. For these patients who have lesions of uncertain malignant potential, NCCN has acknowledged that gene expression profiling along with second opinion, FISH, and CGH are appropriate to provide additional testing and information. For your patients who have melanocytic lesions of uncertain potential, we will offer your patients the MyPath melanoma assay first. This test has been in existence longer, has studied more patients, and that's why we've elected to start here. If your patient still has an indeterminate result, they will then be tested with the DecisionDX DiffDX melanoma. And it is our intent that we will then eliminate that intermediate result for your patient. If you have experience using one of the assays and you feel strongly that you want your patient to be tested exclusively with either MyPath melanoma or DecisionDX melanoma, you will have the opportunity to call the lab and ask that your patients be tested in a specific way. I wish we had more time to talk about patient management and the gene expression profiling. I truly hope that this information helps in the management of your cutaneous squamous cell and melanoma patients, as well as your patients with melanocytic lesions of unknown malignant potential. I would love to answer any questions you have. My email is there. Please reach out to me, and I hope to see all of you soon in a live format. Thank you.